My dear students, wish you all a very happy and prosperous Deepavali. And with this, in today's video, I'm going to discuss on a few points on interpretation of ROTEM, which is one of the common point of care tests, very useful in a routine day-to-day ICU practice, particularly in bleeding patients. And a few points, if we can remember about ROTEM, it helps us to interpret correctly on the basis of the clinical and laboratory findings and take appropriate steps early. Now, what is this ROTEM? ROTEM is a viscoelastic whole blood test that monitors the process of clot initiation, formation, stabilization, and lysis in real time. So we often talk about ROTEM and sometimes we use analogous interpretation about TEG, although that both are same, that there are certain differences. Now, like any viscoelastic testing, in ROTEM also there is a specimen of whole blood in a cup which is heated to 37 degrees, and with ROTEM the pin oscillates but the cup remains stationary. And with TEG, the cup oscillates, but the pin remains stationary. And by both this measurement of the pin synchronization with the cup reflects the stages of clot formation. Now, this is, you can see that in ROTEM, there is oscillating axis is there of 4.75 degrees, and there is a counter force spring on the over the ball bearing, and with the cuvette and the sample, it rotates, and there is a temperature controlled cuvette holder. And when there is clot formation, this viscoelastic resistance is sensed with the help of an LED light source, and it is detected by the detector, and the data processor processes into definite distinct forms of images. So this is how it works. The blood sample is placed in the heated cup at 37 degrees centigrade, and an oscillating pin or sensor detects this increasing viscoelastic resistance as the clot forms. And from this, the software derives various parameters that reflect the different phases of coagulation. One is the initiation, which is by the clotting time, the amplification and propagation by the clot formation time and the angle, the clot strength by the maximum clot firmness, and fibrinolysis by the lysis indices. So these are the common interpretations, and these are the common parameters which measures the different phases. So unlike the standard lab tests, which includes prothrombin time, activated partial thromboplastin time, fibrinogen platelet count, etc., these are which are static, the ROTEM gives a dynamic global information about how the clot is behaving, which includes platelets, which includes fibrin, the other factors, plus the fibrinolysis, which is in a whole blood environment. So these are the key factors. If we look into the tracings, we find one is the clotting time, that is the start of the clot, which should become at least 2 millimeter in amplitude. So that is the clotting time. The clot formation time, that is the time to reach 20 millimeter amplitude. The alpha angle, which is the slope during clot propagation. The MCF, or the maximum clot firmness, which is the maximal amplitude, corresponds to that intake, which is the strength of the clot, and that is the lysis, or the breakdown of the clot, as it is made by the lysis index, that is at 30 minutes or at the maximum lysis, which can be expressed as a percentage. Now, a lot of times this coagulation factors, anticoagulants, FDPs, tissue expression, all these are dependent by the initial, that is the clotting formation stage, initiation and formation stage. Then the maximum firmness and the amplitude, that is amplitude 10 minutes after CT. These all determine the platelets, fibrinogen, colloids, etc. And finally, the lysis is dependent upon the activity of the fibrinolytic enzymes, the fibrinolysis inhibitors, factor 13, etc. So this serially, if we look forward, we can know about the factors which are responsible during each of these phases, And subsequently, we can find out by exclusion that which are the deficient factors. If we look into TEG, we similarly found that the key parameters have a different nomenclature. R is the reaction time, that is the start of clotting. K is the time until the clot reaches 20 millimeter amplitude, which is analogous to the CT or the clotting time. The alpha angle is the slope of clot strengthening, which is the same. The maximum amplitude is the maximum strength, which is a combined effect of both the platelets and fibrin. And lysis at 30 minutes is the percentage of clot lysis 30 minutes after the maximum amplitude. So that can help us to know about hyperfibrinolysis or such. So both are essentially similar, but if you look into the ROTEM workflow, you will find that the whole blood is the Ra plus reagent in a cuvette. In a TEG flow, the whole blood and the reagent is in cup. In ROTEM, the cup oscillates and the optical sensor measures the resistance, where in TEG, it is the pin which oscillates and the cup remains stationary, and the torsion wire detects the clot resistance. And in ROTEM, it is the digital output based on the LED, which provides the parameters CT, CFT, and the MCF, whereas in the TEG, the analog signals are generated, which conforms to the parameters. Now, physiologically, they're equivalent tests, but they have different instrumentation and terminology. But what can be said is that ROTEM is more automated and user-friendly with reagent-specific channels, while TEG is more manual and sensitive to vibrations. So if you look into TEG versus ROTEM, for initiation, the ROTEM symbol is clotting time. The TEG equivalent is the reaction time. What it means visually is the width of the flat baseline before the curve actually starts. The second phase is the propagation. The ROTEM symbol for is the clot formation time, and the TEG equivalent is kappa or K, which is the time from start to significant curve thickening. Then that is which is taken as 20 millimeter of the clot size. So next is the clot kinetics, which is the alpha angle for both ROTEM and the TEG. Equivalent is the same. And it is what it visually means is the steepness of the curve rise. Next is the clot strength. Clot strength, the ROTEM symbol is maximum clot firmness. Clot firmness when the TEG equivalent is maximum amplitude. And what it means visually by looking at the graph is the maximum width of the curve. And finally, it is the fibrinolysis, which is the maximum lysis as a percentage or lysis index at 30. The TEG equivalent is the percentage of lysis at 30 minutes after maximum amplitude. What it means is the degree of narrowing after reaching the peak. So the rate of fibrinolysis is denoted. Now, ROTEM has also different test channels using different reagents. The XTEM. XTEM is the extrinsic pathway activation, which it denotes. It reflects factors 7, 10, 5, 2, and 1 along with platelets and fibrinogen. It largely reflects the PT state of the static laboratory test. The INTEM, denotes the intrinsic activation, that is ellagic acid or contract, and it indicates the intrinsic pathway plus platelets plus fibrinogen, and it corresponds to the APTT of the standard lab test. The FIBTEM, it is similar to XTEM but with platelet inhibition. So if it isolates the fibrinogen contribution. So therefore, the effect of fibrinogen can be known after seeing the results of the FIBTEM. Next is the APTEM. APTEM is the XTEM plus antifibrinolytic agent, that is, it is used to detect the hyperfibrinolysis. And HEPTEM is INTEM plus heparinase, that is heparin. It is used here to detect the heparin effect. So once the heparin effect is negative, then it can be further help us to know the results of the INTEM. So normally, we do for XTEM, INTEM, FIBTEM, and APTEM. HEPTEM is also available, and another is ICATEM is also there. Modern facilities they also have that looks for the direct thrombin inhibitors. Now, how to interpret the ROTEM? What should be the general approach? First, we look at the clotting time in both INTEM or XTEM and try to find out if it is prolonged or not. If it is prolonged, then it means that the initiation of clot is delayed. So we will have to think of clotting factor deficiency. We will also have to think for anticoagulant or heparin effect, because that can also cause a prolongation of the clotting time. Example, in INTEM, if the CT is prolonged, then we will look for HepTem. So if HepTem CT normalizes, that means because HepTem CT uses heparinase, so that means there is a heparin effect. So it is the anticoagulant effect or the heparin effect. If it is not there, even after in HepTem, it does not normalize, which means that it is not because of the anticoagulant or heparin effect, it is actual for other clotting factor deficiency. So next, after clotting time, look into the propagation parameters, that is the clot formation, the time and the alpha angle. So are they abnormal, that is prolonged or slowed? If yes, that means a slower buildup of clot is happening, and that means possible either because of low fibrinogen or low platelets or platelet dysfunction. So both CFT and alpha angle, if they are abnormal, that is prolonged or slowed, then they will indicate that. Next, we look at the clot strength, that is amplitude 10 or amplitude 5, and the maximal clot firmness. Is the amplitude low? If the amplitude is low, then means the clot is weak, either fibrinogen is low or platelets are low or dysfunctional or both. To tease out, we will have to look at the FIPTEM then, because 15 isolates the fibrinogen level. If 15 is low, then it shows that there is fibrinogen deficiency. If 15 is okay, but extem MCF, maximal clot firmness, is low, then it indicates that the issue is with the platelets. Either we will have a platelet deficiency or poor quality of platelets. Then we look at the lysis index 30 minutes after maximal clot firmness or the maximal lysis as a percentage. Is there a rapid decline in the clot firmness or high lysis? If yes, then there is a hyperfibrinolysis. Then we look into the aptem versus extem comparison is held, because aptem, if it normalizes, that it means that there is hyperfibrinolysis element is there. So this has to be correlated with clinical context based upon whether patient is having bleeding, patient has transfusion requirement with trauma, hypothermia, dilution, etc. There are various algorithms to determine targeted therapy for fibrinogen, for platelets, for fibrinolytics, for factor concentrates, etc. And we can subsequently use them. Now let us look here into this graph. So on your left side, it is the ROTEM in the non-coagulopathy normal patients. And on the right side, it is the platelet with a poor platelet function or thrombocytopenia. Now, if you carefully see, you can clearly distinguish that your CT is in INTEM. You can see that the CFT, the clot formation time, is 87. In extem, in INTEM, it is 67. On the right hand side, it is 444, 449, which means that there is a significant prolongation in the clot formation time. And if you look into the alpha angle is slightly more in extem, and it is almost equal in intem. There is not much of difference. So this is particularly the clot formation time for extem, intem, and aptem. You can see in aptem also, aptem excludes fibrinolysis. So there also you can see that it is sufficient, it is prolonged. Here it is 89 seconds and here it is 398 seconds. So both in extem, intem, and aptem, the CFT, so it is abnormally prolonged, but the FIPTEM A10 is normal, which means that we can exclude that the fibrinogen deficiency may not be the reason. So this is primarily because of poor platelet function. Again, you look into this ROTEM in a non-coagulopathic versus in low fibrinogen. Here you can see the clot formation time for extem, intem, and as well as in aptem, it is abnormally prolonged. So this is again on account of low fibrinogen. Next, you see that this is the ROTEM in non-coagulopathy versus the effect of heparin. that is anticoagulant effect. Here, the cardinal abnormality is the massively prolonged CT and CFT of the intem. If you can note, you will be able to clearly see the intem and the changes that is the prolonged in the CT. So it is 852 seconds CT in the intem as against 200 seconds in case of in a non-coagulopathic patient. Again, this is a left-hand side is the same non-coagulopathic and the right-hand side is the fibrinolysis. So you can, in the standout feature is the rapid decrease in amplitude in all tests except the aptem. So to 0. As you can see, except the aptem, in all tests it is getting reduced. The amplitude is falling sharply, which indicates that this is because of hyperfibrinolysis. So if you go by an algorithmic approach for ROTEM and for TEG, if you see how fast, if it is the CT prolonged, the clotting time prolonged, indicating delayed clot formation, the answer is yes. Then we have to give either FFP or PCC. If it is normal, then you look for how strong it is. If the MCL or the maximum clot firmness is too low, it indicates weak clot. If it is yes, the check 50 MCF and the ROTEM platelet if available. If 50 MCF is low, we give cryoprecipitate. If the 50 MCF is normal or the ROTEM platelet is low, then you have to give platelets. If the MCF is normal and for how long, you look into the lysis index 30, that is after 30 minutes after the maximum clot firmness. If it is lysis index is too high, indicates too much lysis, the answer is yes, then give tranexamic acid. Now the same algorithm can also work for TEG. If just think that instead of CT, you will have to look for the R time. If the R time is prolonged, it will indicate delayed clot formation. If the answer is yes, you give FFP or PCC. If it is normal, you look into how strong it is. If the maximum amplitude is too low, does it indicate a clot in weak clot? Then you have to check, and for the platelet mapping or FF, if it is available, you give cryoprecipitate and or you give, if the platelet mapping is low, give platelets. If it is normal, then you look for the lysis, percentage of lysis at 30 minutes or after 60 minutes. If it is too high, indicates too much of lysis. Answer is yes. Then you give tranexamic acid. So this is how you have to be treated based upon the ROTEM. That prolonged clotting time likely causes initiation failure because of low coagulation factors or anticoagulants. Suggested treatment should be FFC or PCC or reverse anticoagulant in case of anticoagulant induced prolongation of clotting time. For low MCF and low 50-metan, the likely cause is low fibrinogen, so you have to give fibrinogen concentrate or cryo. For low MCF but normal 50-metan, the problem is in the platelet, so give platelet transfusion or improve platelet function. For high ml maximal lysis or low lysis index, that is the rapid lysis, low lysis index at 30 minutes, the likely cause is hyperfibrinolysis. So you have to give antifibrinolytic like the tranexamic acid plus adjunct management. If the intem clotting time is very, very high and which is normalized by heptem clotting time, then the likely cause is heparin effect. So the treatment should be to reverse the heparin and alter the anticoagulant strategy. Let us see one more example. Extem CT is 120 seconds, which is prolonged. CFT is 200 seconds, which is also prolonged. MCF is 25 millimeters, which is low. FIPTEM A10 is 5 millimeter, which is very low. MCF is also after that is very low. So interpretation is initiation of clot is delayed, propagation is slow, clot strength is weak, fibrin indicates fibrinogen is severely low. So the conclusion is that primary problem is fibrinogen deficiency, which and is likely dilutional or coagulopathic state. The treatment should be give fibrinogen or cryo and consider FFP if the coagulation factors is also low. There are some practical points and caveats that pre-analytical variables matter, so results must be interpreted in the clinical context. The reference ranges vary by assay, equipment, and population. The ROTEM always complements but does not replace conventional coagulation tests and clinical judgment. So always go for the conventional coagulation tests at appropriate time and don't always judge only on the basis of ROTEM. Algorithms exist that use ROTEM to guide therapy, and you can follow those algorithms. Interpretation requires training and experience. Not all abnormalities are straightforward. For example, just like in ABG, we can have mixed disorders. In ROTEM also there can be mixed disorders. Like there can be low fibrinogen with platelet dysfunction with hyperfibrinolysis. And in those cases, you have to, with experience, we will be able to determine and along with the presenting features and other parameters. And also that it is device specific because different manufacturers or different models may have slight differences. So at the end, the key takeaway from this graph would be the normal trace rises smoothly, reaches a good amplitude or the maximum clot firmness and stays flat, that there is minimal lysis. In hypocoagulable trace or in a weak trace, there will be slow rise, low amplitude, and maybe a short plateau. In hyperfibrinolysis, there will be rapid drop after the peak, whereas in hypercoagulable state, there will be very steep angle, high amplitude, and maybe minimal lysis. Thank you very much.